Good morning. I'm Massimo Antonelli, the head of the Department of Intensive Care and Anesthesiology at the Catholic University in Rome, Italy. My topic today will be the discussion regarding the use of non-invasive ventilation high-flow oxygen therapy in a COVID-19 patient with acute respiratory failure. These are my conflict of interest. When we speak about the COVID, one of the major problems concerns the capacity. The rapid surge with an exponential increase of the cases created a strong impact on the sustainability of the healthcare of the care system. Under these conditions, it happens that at times the number of patients arriving at the emergency department exceeds the capacity of patients of the hospital. And in this case, we have several examples. One of those, at least in one of the epicenter of the pandemic in our country, shows that after a few days in March, despite the increasing capacity of the ICU, the number of patients arriving at the first aid was indeed overwhelmed this capacity, and then the colleagues were obliged to treat a number of patients with non-invasive ventilation or high-flow oxygen therapy also outside the ICU. If we look at the various opportunities of therapy for the ARDS in general, we know that non-invasive ventilation as well as high-flow oxygen therapy may regards mostly the patients who do have a mild ARDS. Indeed, for these patients, the possible treatment that has been applied in the real life, where the CPAP delivered through the helmet or non-invasive ventilation, and the high-flow nasal cannula, in general for less severe hypoxemic patients. When these patients were intubated, then the use of PEEP between 8 and 15, the PEEP LATA below 28, and driving pressure below 14, together with the use of proning, were fundamental hallmarks. Why the high-flow oxygen therapy? Because it delivers high flows and full humidification. And one point can also assure a stable FeO2. Indeed, if you look at the way in which patients with acute respiratory failure breathe, may express something like a flow rate in a minute that exceeds 60 liters. Under these conditions, the conventional oxygen flows at low rate cannot assure an adequate and precise FeO2. We have potential advantages and problems with high-flow oxygen therapy. For sure, as mentioned, the accurate FeO2 delivery, and there is the possibility of correct washout of nasopharyngeal dead space, the provision of small degree of positive pressure, and certainly the improvement of comfort and compliance. But for the COVID-19 patients where aerosolization plays a fundamental role for the contagion and the diffusion into the environment, and where the thermal gases generated from sneezing or coughing may just exceed 1 or 2 meters and just being dispersed within a range of 7-8 meters, it's important to have a correct use and adequate selection. Better if these systems are used in negative pressure rooms. But this implies also that all the personnel that has to take care of these patients need to wear full protective measures in terms of masks, goggles, respirators, hemorrhapellent surgical gown and gloves. But let's look at what happened in the real life. This is a study that has been recently published, still online, done in China on more than 290 patients. And no ventilation in the 77% of these patients. Primarily, they received high-flow oxygen therapy and primary and non-invasive positive pressure ventilation in region of 8.3%. And if you look at the differences between those who had a failure and who has a success, you may realize that those patients who are successful had indeed a lower rate of dyspnea, and their oxygen saturation was higher than those patients who were prone to fail. And the same trend was demonstrated also by the endotracheal intubation, where 65% of the patients who received, who had failure, had indeed an intubation, and their mortality rate was much higher in comparison to those patients who avoided the intubation rate. Interestingly, also if you compare not only successful and unsuccessful patients, but also survivors and non-survivors, the age is higher for patients who didn't survive, or their dyspnea rate was higher as well, the intubation, endotracheal intubation, and the length of stay in hospital was shorter. And if you can see from the graphs that after 1 day, the use for successful patients of high flow oxygen therapy corresponded to amelioration of the gas exchanges in a clear-cut way. Interestingly, the group of Elia Souley in France has investigated the potentiality of these approaches in terms of oxygenation in patients who are immunocompromised with COVID-19 infection. Most of these patients that were included in the study had indeed hematological malignancies, and the number of quadrants that were interested by the inflammatory process were indeed very often full. If you look at the characteristic and outcomes according to third oxygenation strategy, you may see that basically at 1 day there was a difference in terms of patients who receive only non-invasive ventilation or only high flow oxygen nasal cannula, or the combination of the two. And in this case, the number of patients who had indeed a lower PF ratio below 100 were more numerous, and in the group that received the combination of the two techniques. And the SOFA score was almost comparable, but slightly higher for those patients who received the combination as well. Invasive mechanical ventilation was more frequent for those patients who failed, and the 28-day mortality was lower for those patients who received the combination of the two techniques, whilst the length of stay in the hospital and in the ICU as well as was shorter for these patients, and the hospital mortality higher. Looking at the multivariate logistic analysis, the most protective combination was indeed represented by the use of non-invasive ventilation and high flow oxygen therapy. But whilst the probability of being intubated in this group of patients were proportional to the severity score depicted by the SOFA score, the proportion between the PaO2, FaO2, and the adjusted probability of intubation is more dispersed and strictly dependent upon the severity and the kind of system to deliver oxygen. Another possibility is represented by the CPAP, or non-invasive ventilation delivered through a helmet, provided the fact that you can assure to these patients an high flow rate. But once again, you have to consider the diffusion of micro droplets into the environment, and having a hook like the helmet, and by using HEPA filter at the expiratory phase may be helpful for containing into a closed environment these nebula, this gas of turbulent, this cloud of turbulent gas, in order to reduce the dispersion, at the same time assist the patient in an adequate way. Interestingly, it has been investigated by the group from Monzo, Giuseppe Foti, the possibility of using the helmet ventilation and helmet CPAP in COVID-19 patients, proning them. And this is the figure that represents a healthy volunteer who's showing how it works. And this is the circuit, this is the helmet, and this is the delivery system. And interestingly, in this study, there were enrolled 47 patients who were proned successfully, and 23 of them were responders, and 23 were not responders. If you look at the various situations and at the same time, the difference between the supine versus prone position, you may see that under these conditions, prone in the patient representing an advantage in terms of reduction of the respiratory rate and dyspnea, with the possibility of applying a level of PEEP relatively high and more efficient for recruiting these patients. It is very demonstrative looking at this slide where the patients had a trajectory represented by the situation in prone position where the PaO2, VO2